Good morning, everyone. Welcome to the conference session titled Advances in Treating Aplastic Anemia, and thank you for joining us. My name is Lisa Udelson. If you're here, you or someone close to you found a bruise, a lot of bruises, maybe a mysterious bloody nose, and face mortality, perhaps for the first time. At least that's what it was like for me in 2015. Early in my aplastic anemia journey, I kept hearing, Ron Paquette, he's the guy you want if you have a rare blood disorder. I was lucky enough to find my way to the guy. Dr. Paquette said, aplastic anemia, I love this diagnosis. It makes doctors look good. He gave me hope, answers, a lot of laughs, and a treatment plan. I've been in remission since 2019, and 8.5 years since those first bruises, I've never felt better. I think the world of Dr. Paquette and am ever grateful. As we get started, AAMDSIF would like to recognize the generosity of the corporate sponsors, diamond level sponsors, Alexion and Novartis, gold level sponsor, Apellis and Genentech, and the generous support of patients, families, and caregivers for support of the conference today. Immediately following the presentation, there will be a question and answer session. When asking questions, please wait for the microphone so everyone can hear the question you're asking. Please do not share private health information in your question. The speaker cannot answer any specific questions related to your health care. If you're participating online, please type in your questions in the Q&A window at the bottom of your screen. Today's specialist is Ronald Paquette. At Cedars-Sinai in Los Angeles, Dr. Paquette is a professor of medicine, director myeloid malignancies, clinical director, stem cell and bone marrow transplant program, and a staff clinician. He is a member of the Medical Advisory Board of the Aplastic Anemia and MDS International Foundation. With that said, it is my great pleasure to introduce Dr. Paquette.
Thanks so much, Lisa. Not only does treating aplastic anemia make the physician look good, it's one of the most gratifying diseases to treat, and it's never been more gratifying than now because patients come in and they're very, very ill, but their prospects for living a normal life are perhaps excellent, and the realistic possibility exists for every patient that they could be normal. That's what everybody wants. They want to be normal in spite of having a very difficult initial presentation and initial difficult course of therapy. My slides are not super new, but I think going over the basics is very important because out in the community, oftentimes patients are perhaps they're unusual. It's a very rare diagnosis, and many clinicians may not know all the details of the care that should be provided and the nuances of care. And so to be informed as well as possible, to be an informed patient, you can be your best advocate. And I think that's the most, that's the thing that I can perhaps best convey to you. So we will see. So, let's see. This way? No. Which one do I press? This one. Nope. Okay. Anybody know which button to push? We're having some technical difficulties here. How do I advance the slides? Can anybody show me which button to push? This is challenging. did you use? Yeah, it's not working today. I can go through this without the slides. I tried all the obvious things. Okay. We're working on it. So anyway, as I was alluding to, patients with aplastic anemia often come into medical care very sick. One or more cell types will be very low, and so when the white count's low, patients will present with infections, oftentimes serious infections. They almost always have anemia and can have profound fatigue, tiredness, shortness of breath with exertion. There we go. What do you know? All right, now it's working. Is that right? Okay. And if the platelets are low, there can be bleeding. There can be what can oftentimes be misinterpreted as a rash, but it's really petechiae, which are little red dots in the skin due to the very low platelets with blood leaking into the skin. Easy bruisability is also often observed at the time of diagnosis. And so not just one cell type, but oftentimes 2 cell lines or even 3 cell lines are going to be severely depressed. And when this is first noted, it can be due to a number of different conditions, and only the bone marrow biopsy will disclose what the actual cause of the low blood counts is. And so this has the bone marrow has a very characteristic appearance, and that's over on the left-hand side. You see all those little empty spaces. That's where the cells should be, but instead are replaced by fat, as opposed to a normal bone marrow on the right for about a 40 or 50-year-old, where there's only about half the bone marrow space is comprised by fat. So there's been a very profound effect of the cells in the bone marrow. The stem cells have been attacked by the immune system, and they're markedly depleted, leading to low blood counts on the CBC. So what causes aplastic anemia? Well, more and more, we've been recognizing that certain gene mutations that can be inherited can be an underlying cause, but in reality, this is only a small percentage of cases in the adult world. Historically, medications have been implicated in the causation of aplastic anemia, but I think to a large extent, many of these drugs are no longer used, and there are still some that have a strong relationship to the causation of aplastic anemia, but this is generally not so common. A rare situation is that a patient will present with severely abnormal liver function tests, be diagnosed with an autoimmune hepatitis, and then later on have aplastic anemia. But in general, this is an immune-mediated disease in which the immune system is inappropriately attacking the bone marrow stem cells. So how do we know this is immune-mediated? How do we know the immune system has gone awry? Well, we know that aplastic anemia is statistically associated with certain tissue types. They are not common enough to use as a screening test. This is a rare disease. And although it's statistically associated with certain tissue types, that's not a very high predictor of who will or will not get aplastic anemia. Nevertheless, when patients have these tissue types and they have aplastic anemia, if the stem cells can figure out how to no longer express these tissue proteins on their surface, then they can no longer be recognized by the immune system and are able to escape from the immune attack, and then prolonged remissions can occur. There's not a way we can instruct the stem cells how to do this, but nevertheless, this has been observed repeatedly in such scenarios. We know in particular that this is an immune-mediated disease because the majority of patients will respond to immune suppressive drugs. We know that gene mutations, some of which Dr. Becker mentioned in association with myelodysplastic syndrome, can also be seen in aplastic anemia. When these mutations occur, they don't mean that the patient is necessarily going to develop myelodysplastic syndrome, however. It's more of a stress response of the stem cells to the immune attack. If they happen to have a gene mutation, then they're more likely to survive the immune insult that's ongoing in the bone marrow space. Some mutations are actually favorable predictors of a response to immunosuppressive therapy. And the PIGA gene is a good example. That's the one that's mutated in paroxysmal nocturnal hemoglobinuria, or PNH. And we know that patients who have this will have more likely chance of responding to immunosuppression. And it doesn't necessarily mean that they're going to go on to develop true clinical PNH. Other mutations are associated with an increased risk of ultimately developing myelodysplastic syndrome or even acute leukemia. So when a patient first comes in with aplastic anemia, we have to characterize the severity of their disease, and that's important for deciding which therapy might be most appropriate. The majority of the patients come in with severe aplastic anemia, which means that 2 or 3 cell types are very severely reduced, as is shown up there. Neutrophils less than 500, platelets of less than 20,000, and then reticulocyte count, which is a measurement of red cell production, less than 20,000. Very severe aplastic anemia means the neutrophils are less than 200, and that means that they have a significantly lower response to immune suppressive therapy. And then moderate aplastic anemia is also important to distinguish because the blood counts are lower. I mean, they're lower than normal, but they're not severely low. And there's not really a traditional or widely applied approach to medical therapy of patients with moderate aplastic anemia. And these patients don't necessarily have a serious or life-threatening condition like severe or very severe aplastic anemia. So when patients present, we have to make the decision based on age, based on disease severity. Should a transplant be the best initial consideration, or should immunosuppressive therapy instead be considered? This is one treatment algorithm that was published in 2018. This just gives an example of the kind of thought process that must occur. And this is an ever-changing situation. Every center will have a different flow diagram. It just gives an example of what happens. So if we have a younger patient, and younger is defined perhaps by the age of the physician. Younger means younger than me, certainly, but as transplant outcomes improve, the age at which we would consider transplant as initial therapy tends to be going up and up. So I don't know what it is at your center. It's 45, maybe 50. If there's a fully matched related sibling who's younger, 45 would be potentially appropriate as to use a transplant in first remission. And then as we see here, haploidentical transplants before used to be a very dangerous proposition. At our center, 85% of our transplants nowadays are done with half-matched donors. And now that there has been at least one report of using haploidentical transplants with very excellent outcomes, this should perhaps be moved up. And I don't know where you designate haploidentical transplant in such an algorithm, but these decisions are changing and they're very center specific. But nevertheless, a patient who has severe aplastic anemia should be evaluated at a center in which all these possibilities can be implemented. And I think that's the most important point, is that this is a complex decision-making process, and all the patient and donor variables should be taken into account when making the decision of transplant versus immunosuppressive therapy. So these are still old data, ever-evolving data, but you can see that these are survival curves of patients with severe aplastic anemia. And you can see this isn't working, for the thick blue line represents the survival outcomes of match-related donors, and they have traditionally been the best. But I think as our experience with haploidentical transplants is increased, those are the dotted green lines, those will continue to improve. And decade by decade, the survival of patients who undergo transplant progressively improves over time. And so this is the single most important decision when someone comes in with severe disease. But you can see the chance of long-term survival is really excellent for patients who undergo allogeneic transplant. Immunosuppressive therapy is a backup plan for older patients or patients for whom a suitable donor isn't immediately available. And this treatment recipe hasn't changed for perhaps 10 years. And it involves 3 drugs. So one drug is anti-thymocyte globulin. That's been around since the 1970s, late 1970s. And that's basically horse serum that has been generated in a horse against human thymocytes. And so it's given intravenously and it goes into circulation and it kills the T cells. Time-honored approach used by itself has about a 50% response rate, but then a decade later, cyclosporin, which is a oral therapy that suppresses T cell function, was added to ATG and further improved the response rate from 50 to 65%. And then more recently, eltrombopag, which is an oral medication that acts like thrombopoietin. Thrombopoietin is a growth factor for platelets, but it's also expressed on stem cells. So when thrombopoietin is added to stem cells that are under attack, it allows the stem cells to survive better the immune attack while the immune system is being suppressed enough to then allow them to repopulate the bone marrow. So when this was added to ATG and cyclosporin, the response rate goes up as high as perhaps 85%. And then a higher percentage of patients can actually achieve complete remissions when all 3 drugs are used as opposed to getting just 2 drugs. We know that the survival of patients who respond to triple therapy is excellent. But it does come with some risks. And so ATG is probably the harder drug to get because it can cause serum sickness where patients develop antibodies against the horse antibodies. And then these so-called immune complexes can cause a skin rash, joint pains, fevers, and a lot of uncomfortable symptoms that have to be prevented by giving high doses of steroids and then managed by giving additional steroids when the rash occurs. The other risks are that some patients will go on to develop secondary blood disorders like myelodysplastic syndrome, acute myeloid leukemia, or paroxysmal nocturnal hemoglobinuria. The single biggest risk is that patients will have about a 30 to 50% chance of having a relapse when the cyclosporin is tapered. So this is the one aspect of immunosuppressive therapy that hasn't been subjected to very careful study. How long should the cyclosporin be used and how should it be best tapered? And I think everybody has their own best practice. I have one approach that I've used for many years, and I go down very, very slowly. The NIH initially would just continue it for 6 months and then stopped it. But then they found that the relapse rate was very high when they did that, so they continued a lower dose for a longer period of time. And there's not a strategy that's universally used across centers, I would guess. Anyway, I taper very slowly, and most of my patients are on immunosuppression with cyclosporin for 3 years or more even, as we very gradually taper down the dose. So there's a lot of different ways this could be managed. This shows the results of a randomized trial of ATG and cyclosporin versus ATG, cyclosporin, and Promacta. And you can see over on the left curve that shows the response rate of patients who got 3 drugs, which is the orange or pink curve, and versus those who just got 2 drugs, which is the blue curve. And you can see that the incidence of response was more than 10% higher for patients who got 3 drugs, very convincing. And then the incidence of complete remissions on the right-hand side also shows a significant superiority of 3 drugs over 2. So we use these 3 drugs with absolute confidence because patients do better when they use 3 drugs. This again just underlines what I just told you about discontinuing cyclosporin abruptly at 6 months. This is the NIH data. So and then this curve represents the risk of disease relapse. So when patients only got cyclosporin for 6 months, that's the upper curve, they had an over 50% chance of relapsing within a year. If it was continued for longer, the risk of relapse was was dramatically lower. And I think this just reiterates the fact that although these treatments can be very highly effective, most patients need a longer exposure to cyclosporin to have the best possible outcomes. So only about half of patients can have completely normal counts, and that can cause a lot of anxiety. Anxiety on the part of the patient, like, my white count's so low, my hemoglobin's so low, my platelets are so low, what do I do? Well, not to worry. This is important to realize that, is that patients who have less than a complete response can still live normal lives, and their response can even improve after a year or with more prolonged treatment, particularly with ongoing cyclosporin. And the survival is exactly the same as patients who have complete normalization of their blood counts. And so anxiety should be put aside. This is the one disease that takes the most patience on the part of the patients, because it's not fast. It can be slow in terms of the rate of response. And consistent, the one thing that's really important is consistently taking cyclosporin, and being able to take the medication long-term is important to achieve the best long-term results, in my opinion. So what level of response is good enough? Well, I think those that don't cause symptoms predominantly. So platelets, the minimum over 20,000, because people, even with 25,000 platelets, don't have repetitive bleeding under most circumstances. Neutrophils over 500 is generally a safe number. Over 1,000, of course, is better. Hemoglobin, everyone has a different threshold for tolerance of a low hemoglobin level or a certain degree of anemia, but we don't really like patients getting long-term transfusions, if at all possible. So those are kind of like the lowest bar that would make someone be pretty close to normal in many situations. This is just, again, underlining what I just told you. This shows on the left-hand side of the graph, the green, I'm a little colorblind, so help me out here. The green and the blue curves on the left represent patients who have had a complete or a partial response to immunosuppressive therapy, whereas the red line, no response to therapy. You can see how excellent the outcomes are. If you have any response to therapy, your outcome is going to be amazing. This is 5-year data. This is great. The patients who don't have a response, however, have less superior outcomes, but those are the patients who are getting transplant as a second line of therapy. So not all is lost. There's a backup plan for the majority of patients who have inadequate response or no response to immunosuppressive therapy. And you can see on the right-hand side is the other thing that's very reassuring. If someone has if they've had a response to therapy and they've had a relapse, the chance of being able to recapture that response is certainly over 50%, but higher, and their survival is the same as if they didn't have a relapse. We don't want a relapse. We want to try to avoid relapse, but when it happens, not all is lost. So that should be reassuring as well. This is just a side note, is that many patients with low white counts get white cell growth factors, but that's never been established as being beneficial in terms of response rate or survival. So it can also potentially decrease the level of blood counts that you do need, like platelets. So I think it's best avoided. All right, so what happens if ATG doesn't work the first time around? Well, I think that's the best indication for transplant, if transplant could be orchestrated in some fashion. So as I mentioned, using a half matched related donor, using a matched unrelated donor would be the best possible strategy for such a situation. We don't do umbilical cord blood transplants anymore. I don't know if they're still done. No, not at all. Not for aplastic anemia. We don't do any at all for anything. But generally, this has certainly been abandoned for aplastic anemia due to the high risk of graft failure. If transplant's not an option, then horse ATG can be used again. Bunny, I call it bunny ATG, which is thymoglobulin, where antibodies are generated in rabbits as opposed to horses. Those have about the same response rate of around 30%. So 30%, you'll take it if you need it, but in general, transplant would be a better approach if at all possible. Sometimes just prolonged cyclosporin can generate responses which over time continue to improve and actually can reach normal levels. I've had patients who failed ATG twice, went on experimental trials, did everything, but continued the cyclosporin and achieved completely normal levels, were able to be tapered off and are still alive and in remission many years later. So there's so many options. You just have to keep pushing, keep trying, because even prolonged immunosuppression can be with cyclosporin can be useful, and prolonged L-trombopag or Promacta can also be useful. So I mean, there's so many scenarios, but I had a patient who also didn't respond to anything, didn't want a transplant, and then went to the NIH to receive Promacta on the clinical trial of Promacta for patients who had not responded to many different therapies. He got enough benefit from that 10 years later, he's still on it, but he didn't need a transplant. So he's happy. I'm happy he's doing well. He's still fully active and has an active medical practice. So many possibilities exist. The bottom line is keep trying, and if conventional options are not available, clinical trials are an important option to consider. So here's just the trial that I mentioned. This was conducted at the NIH, where 40 patients were treated with Promacta, and generally the standard dose is 150 milligrams a day. They recommended using half that dose for patients who have Asian ethnicity, because it can lead to some increased liver function abnormalities. But the response rates were pretty reasonable for using a single agent for patients who hadn't responded to other therapies. And so about half of patients had improvement of at least one cell type, and about a third of patients had improvement of multiple cell types. So, and these responses are generally maintained long-term. As I said, my one patient who was on this trial is still taking it 10 years later. The one thing is that the patient population of aplastic anemia, patients who have not responded to multiple therapies, have a higher chance of having gene mutations or chromosomal abnormalities. I don't think the treatment induces this. I think it allows the stem cells to survive in a damaged state, or allows the patient to survive in a situation in which this stem cell injury has been more profound. And so it's not surprising that there's an evolution of cell populations that are abnormal. So it's important to be aware of complications that can result from these various different therapies. And let's see, some of these can arise late. So the main thing, as I mentioned already, is that relapse can occur, and it happens in at least a third of patients who are tapered off immunosuppression. It can be retreated when relapse occurs. I think if relapse occurs when cyclosporin is being tapered very gradually, it's less likely that it's going to be profound and require a second course of ATG, which is why I always go down on the cyclosporin very, very slowly. Again, everyone has a different approach to this. Myelodysplastic syndrome can occur in about 10 to 15% of patients, and PNH perhaps higher than 10%, but we also can see that as a late complication if not present early on. How much of a drop is important? Well, anything that shows a trend of declining counts, especially if they're no longer in normal range, I think warrants some consideration. If the decline is not associated with a very gradual tapering, then considering a bone marrow biopsy to reevaluate the underlying cause of the low counts is important. To rule out myelodysplastic syndrome or PNH, for example, is the standard approach to significant fall in blood counts. And so relapse is more likely when cyclosporin is discontinued abruptly, or it's tapered too rapidly. I didn't mention this, but some patients will have aplastic anemia occur while they're pregnant. If they have a second pregnancy, there's about a 19% chance that the aplastic anemia will recur under those circumstances. I don't know the answer to this, but I have heard anecdotes, and I've had one patient have relapse of their disease even in remission after 10 years when they had an influenza vaccination. Any thoughts on that? What do you tell patients about vaccination? Now, standard vaccinations are okay, but I think this is an area where there's some controversy and incomplete knowledge. It could be coincidence. 10 years seems like a long time to be in remission and then just get a vaccine. Right. There's no way to, I don't think there's a way to know. It's a question mark in my mind. So patients are more likely to develop myelodysplasia if they're older with the onset of their disease, if they have certain gene mutations, if they haven't responded to immunosuppression. But it can happen even in patients who have had a complete remission on immunosuppressive therapy. So this is the thing from the standpoint of the physician that requires the most attention in my mind, because cyclosporin often is required long-term, have to respect the kidneys. The kidneys have to be there along for the whole ride. So this is managed, in my mind, a lot like management of solid organ transplant, where if there's some decrease in kidney function, you have to address, it has to be addressed by the physician by lowering the cyclosporin dose, because if the kidneys can't tolerate it, we're going to run into trouble down the road with progressive kidney insufficiency. And so careful attention to the creatinine level, which is a measure of the kidney function, is very important as cyclosporin treatment proceeds. And there should be a rapid response to significant changes in the creatinine level. I think the minimum effective dose of cyclosporin, I don't follow levels per se because it's never really been validated as a way to, in aplastic anemia anyway, to determine the suitability of the dose. But 2 milligrams per kilogram of body weight per day appears to be about the lowest dose that has real clinical activity. And then measuring, controlling blood pressure can be important in minimizing negative impact of cyclosporin on the kidneys, because cyclosporin raises blood pressure in the majority of people. This is one that really flies under the radar, avascular necrosis. What is that? Well, it's a condition that arises in which there's decreased blood flow to critical joints, and in particular, the head of the femur. And that when that happens, the bone can die, but it can not be appreciated for many years after the actual injury. And so this can happen in the hips most commonly, but also the knees and the shoulders, or all of them altogether. This happens as a result of high doses of steroids. So if someone has a particularly bad episode of serum sickness associated with the ATG, or even just the doses that are used to prevent serum sickness with ATG, this can induce avascular necrosis. And it may not show up for 3-5 years after the steroid exposure. And it presents as lingering or progressive pain in one or more of these joints. And it can also be not appreciated because plain x-rays won't show the abnormality unless it's very far advanced. And so MRIs are the one kind of gold standard way of detecting this abnormality and potentially addressing it. Unfortunately, the really only effective treatment is replacement. And so in general, patients should try to put up with it as long as they can until they're willing to undergo a joint replacement. Doing coring procedures, I don't think really works. But nevertheless, if someone has chronic pain in the hips or the knees or the shoulders, this is one consideration that is worth following up on so it can be monitored prospectively. Iron overload is also an issue for patients who have had disease for a long time. And so iron chelation therapy is typically implemented if there's ongoing need for transfusions, and the ferritin level, which is a measure of the body's iron stores, is over 1,200. There are a number of different drugs that are available. The one that's most often used is Xjade or Jadenu, but this can be really hard to use in conjunction with cyclosporin because they both impact the creatinine level. So that makes it hard. And so desferal can be inconvenient, and deferiprone can cause neutropenia. So there are disadvantages potentially of any of these things. And so this is a clinical decision that has to be worked on with the physician. So the great thing about the prospects of treatment for aplastic anemia is that the outcomes can and should be excellent, and nothing less should be accepted. We only should accept excellent outcomes for the patients for the aplastic anemia. But the initial decision-making is really critical. And so having evaluation at a center that is capable of doing a transplant is the most important initial step. And then I think that having an expert at least weigh in on the management at some point can be quite useful. There's, as you can see, there's many nuances to the care of patients. Even though the approach is very much standardized, the nuances in care I think are very important to address. And so having someone at least who treats a lot of these patients, see and consult about care can potentially be useful. Of course, I'm very biased here. I'm biased. Admittedly, I'm biased. And then having everyone be aware of the complications that can occur as a result of the therapy can be helpful in addressing and potentially avoiding them. And then clinical trials continue to be important, but there aren't many places that see enough patients that can actually do trials. And so the NIH is the one place where this is still possible. And okay, let's all show up in 2 weeks, and actually 2 weeks from now, to the March for Marrow down in Long Beach. And you can see this is a lot of fun. Everyone should show up and participate. This is a great event. All right, questions, comments, experience. Sorry, I didn't see how long I was talking. Hopefully it's time for questions. Did I run over? No, you're great. Okay.
One of your earlier slides, unless I misunderstood the slide, I think there was a mention of the risk of patients with AA developing PNH and or MDS. Is that more attributable to the fact that the patient has an AA and or is that more attributable to the triple therapy that you had mentioned? And if the latter, did they determine out of the triple therapy drugs, which one in particular may contribute more to the development of MDS or the PNH?
Great question. So it's so what happens is that there's an immune attack against the stem cell, and then so there's marked loss of stem cells as a result of that immune attack, and so the remaining stem cells will do anything that I'm talking like the stem cells have a choice, but they really don't have a choice. They do anything they can to survive this immune attack, and one way to avoid the immune attack is to lose the expression of proteins on their surface that are the target of the immune response. The immune response happens because the immune system is inappropriately recognizing proteins on their surface as being foreign, and the immune attack is orchestrated against the cells that are expressing those proteins. So as we all have mutant stem cells in our body to some degree, and the ones that are more likely to survive are those that are no longer being recognized by the immune system. And so there's a selection bias killing off the normal cells to allow the crabgrass stem cells to grow back in the place of the normal ones. So it's a selection process that allows these cells to survive, proliferate, and become dominant. And that's because they're carefully selected by killing off all the normal residual cells. Cyclosporin, Promacta, ATG don't in any way cause additional damage to the stem cells. It allows the evolution of cells that harbor these abnormalities. These are random events, but they can be recognized just by the fact that the normal cells have been markedly depleted. And there's ones who have mutations that can then give rise to the subsequent disease processes have a survival advantage as a result of the immune attack. So these things are made possible because the median survival before we had immunosuppressive therapy, the median survival of a patient with severe aplastic anemia is 3 to 6 months. So half patients were dead in 3 to 6 months. So patients are surviving now for many, many, many years, and so we can appreciate that certain things that have permitted their survival are abnormal, but not necessarily abnormal in a way that's going to progress in every person. It's like I told you, 50% of patients will have gene mutations, but not 50% of those patients will go on to have MDS or AML. So it's a little bit of a luck of which mutations have allowed the stem cells to survive and whether or not they have a predisposition to develop into a disease that can have clinical significance beyond aplastic anemia.
Yeah, thanks for that. I actually had nearly the exact same question. So I'll just ask a follow-up. If you were in a situation where you saw the emergence of PNH, and specifically in our case, the patient's less than 40 years old, how might your treatment plan differ, based on that news?
That scenario is actually pretty common. And so this is something that I see a situation which I think is oftentimes overtreated, and it's pushed a little bit by how people are instructed about using PNH like drugs. So not everybody who has a PNH clone requires therapy, and it's actually favorable prognostically to have one because, again, immunosuppressive therapy works better in that situation. Historically, which percentage of a PNH clone is clinically significant in an aplastic anemia patient that requires some form of therapy? And the data here is this is rare, right? So aplastic anemia is 1 to 2 patients per million population. PNH is a tenth of that. So it's really a small number of patients. And so what is the main risk for a PNH patient? Although it's manifested as anemia due to hemolysis, the real risk is clotting. So the real risk is clotting in an inconvenient place like the liver, in the blood vessels that lead to the spleen, sometimes even in the brain. These are serious things that can happen. So which level of a PNH clone predicts for an increased risk of clotting that needs to be addressed? Historic is only like one paper that I know of that actually tries to address this, and they found a cutoff at around 50%. So that would, if someone's not on a PNH therapy, and we know the PNH therapies can significantly reduce the risk of clotting, but in the absence of having had a clotting event, lower percentages probably don't require such therapy unless someone has symptomatic anemia or symptoms related to the PNH per se. So that's based on very, very limited data. And so, but the other thing is that the PNH clone may not actually expand over time. It may remain very, very stable and not have clinical significance. Hardly ever. I mean, there's some people who remain completely stable. It doesn't necessarily expand over time. So there doesn't need to be a knee-jerk reaction if someone has a 15% PNH clone. And again, I should mention that the percentage of the clone size, this is the population of cells that has a mutation, should be measured in the white blood cells and not the red blood cells, because the red blood cells that have the mutation are all being wiped out. But because the mutation occurs in the stem cell, the white cells also have the mutation. They can be measured, and they're not destroyed by hemolysis. They're still around. So the granulocyte percentage, the monocyte percentage of PNH cells is the most accurate way of determining the size of the clone. And I think as it approaches 50%, consideration should be to provide anticoagulation or therapy for the PNH with a complement inhibitor. But this is a clinical decision that's complex. No. Transplant for PNH, I think, there's so many effective transplant carries, even you saw the survival is amazing, but there's still a chance of death from transplant, which I'm a transplanter. I love transplants too, but you don't want to kill somebody with it. The treatment can't be worse than the disease. That's the bottom line always. Treatment can't be worse than disease. And I think unless there's severe aplastic anemia accompanying the PNH, we wouldn't want to jeopardize somebody's life with a transplant when medical therapy carries such an excellent prognosis.
Thank you for that, Dr. Paquette. We did have someone send in an email for you, and it says, "Hi, Dr. Paquette. Thank you for helping save my life 16 years ago. I was given ATG and cyclosporine in early 2009, and I've had a long, slow, durable response. My current doctor has tried to take me off cyclosporine starting in 2012, and my platelets quickly fell. Luckily, it was recoverable by reintroducing the drug, and I've been on a low maintenance dose ever since of 2.5 milligrams. I am living a full and active life and barely notice the drug, except now I have a high cholesterol, which I see as a side effect. My blood pressure has been fine. My question is, do you have any more recent data on the ill effects of long-term low-dose cyclosporine? Should I risk tapering again or stay the course? Am I considered to be on cyclosporine dependent for life? Thank you for everything you do and did for me. And thank you to AAMDSIF for all you do."
That's nice. So we were not supposed to have very patient-specific questions. Thank you so much for that. But I would say that the long-term risks of chronic immunosuppression are the ones that I mentioned, i.e. renal insufficiency, the effects of hypertension it can cause. There is also an associated increased risk of lymphoma with chronic immunosuppression. What is the lowest dose that is not of clinical significance? I don't know, but I would say that I never give up trying to get someone off immune suppression. Because a lot of these processes that confer long-term remission, like the loss of expression of certain proteins on the stem cell that are the target of immune attack, can happen later, much later, even years later. So I never stop trying to get people off immunosuppression because it does have potential adverse consequences. And so I would say there may have been a relapse at one time, but I think there's not a contraindication to trying again. And regardless of the dose, 2.5 milligrams, I didn't realize there was such a dose. 25, I can believe. Anyway, thank you for that. Good luck.
Doctor, could you briefly discuss the alternative of tacrolimus for cyclosporin?
Yeah. So, it's tacrolimus is, I think it's probably a little bit better drug in some ways. Historically, we use cyclosporin for stem cell transplant patients. And then maybe 10 years ago, predominantly switched over to tacrolimus. They both have the same mechanism. So they both work the same way. I think tacrolimus is perhaps a little bit better tolerated. It doesn't cause the swelling of the gums that you see, for example, with cyclosporin. The other types of side effects that occur are very individual specific, but since cyclosporin has been time honored and subjected to randomized clinical trials, I always start with that, but I never have reservations about switching to tacrolimus if someone's having side effects that are drug related. So I have less sense for which is the minimum dose, things like that, because cyclosporin I've just used for so long, but I have no reservations about using it to replace cyclosporin if side effects are warranted. It should be, I think really it has equal efficacy.
Hi, my name is Dorian Beaver, and I want to know something. I still get joint pain once in a while, and you said it's due to the ETG. How come I'm still getting it after so many years?
So that's why I'm saying if you had steroid exposure during the ATG, it's possible that avascular necrosis can happen. And you can only really check that with MRI of the joints that are causing the problem. And so it just shows a decrease of blood flow or lack of blood flow to a certain part of the joint, which unfortunately eventually will lead to the collapse of the joint. For example, the head of the femur is the most common place where avascular necrosis happens. And initially the cortex, the outer bony part of the of the hip joint is maintained intact, but over time that will break down and cause more irregularity in the surface and cause progressive pain. But the same is true for shoulder and knee joints as well. It can be the either side of the joint, either in the femur or other bones potentially, that eventually can cause enough erosion of the cortex of the bone that the joint can just break down. So it's not due to the ATG per se, but the steroids that were administered to prevent or treat complications from the ATG.
Hi, my question is in regards to pregnancy. So is there any updated studies or data that correlates pregnancy with being diagnosed with idiopathic aplastic anemia?
It's so rare. I mean, but if it happens, if aplastic anemia is diagnosed at the time someone is pregnant, this is all I know, because if aplastic anemia is diagnosed at the time of pregnancy as the initial diagnosis, then subsequent, as I said, subsequent pregnancies can be associated with a relapse of the disease. That's all I know. But what the mechanism is, I mean, there's a lot of changes in the immune system. When someone is pregnant with a baby, the baby is haploidentical, right? So
Right.
how can your body have something has half the tissue proteins that are different than your own body? Normally there'd be a rejection process, but the placenta is able to mediate, stand in between the mother and the baby to prevent the mother from rejecting the baby. So there's a lot of immune things that happen during the pregnancies that allow that actual process to be successful. But in the process of that, some people will develop aplastic anemia, but what mechanistically what happens or how to mitigate it, I don't think is very well understood because of the rarity of the situation.
Copy. Yep, I have a rarity right here.
It's not 100%, but I can't say that I have any special, but you can take cyclosporin during pregnancy, and you can take cyclosporin during pregnancy. So I wouldn't say that, I'm pretty sure not Promacta, and certainly wouldn't want to get ATG, but being on because people who have solid organ transplants go on and have successful pregnancies, for example. So that's where we have confidence in that situation. Right. Yeah. Cyclosporin maintenance would be possible. Yeah. I wouldn't abandon it. I wouldn't, I still think, yeah.
Thank you, Dr.
Okay.
Paquette. Nikki?
Okay, thanks.
Thank you, Dr. Paquette, for sharing your time and expertise with us.